Hello and welcome everyone. Welcome. Apologies for the delay. We had we experienced some technical issues, but thankfully it's resolved now. So first off, I'd like us to share where we're coming from, where we're watching from. Okay. So if you're joining this session, let us know where you're joining from. You can introduce yourself in the comment section and where you're joining in from. So I've seen two people already. I think the first person who joined in quite early, Faith Opara and Jennifer Amarachi. It's amazing. It's amazing. Thank you very much for joining in. So we'll be getting right into the session. Chukwu a Chukwewegi Solomon. You're welcome, sir. You're welcome, sir. It's really amazing to see men joining sessions like this. Thank you so much. Thank you so much for joining in. Greetings to you. So, Faith, over to you.
Thank you. Can you hear me?
Yes,
Yes.
I can. I can hear you.
Good evening, everyone, and welcome to tonight's webinar. I I want to specially welcome everyone to this webinar. I'll be inviting the speaker now, and I want to beg everyone to pay rapt attention and get the best out of this webinar. Thank you so much, Dr. Remilekun Durojaiye, for having to speak with us tonight. Dr. Remilekun Durojaiye has a diploma in physiotherapy from Bristol Royal Infirmary, Bristol, England, in 1988. She had a master's in PT from the University of Health Sciences, the Chicago Medical School, USA, 1993, and her doctorate in PT from the Alabama State University, USA, 2009. She has been in active practice for the past 38 years. She, she has a board certificate in biofeedback for pelvic floor dysfunction. She's a locum PT at Federal Psychiatric Hospital, Yaba, Clinical Director for Special Olympics Nigeria, and staff for her pelvic and orthopedic wellness physiotherapy clinic and an adjunct lecturer for Chrisland University. She is currently the chairperson of the Nigeria Society of Physiotherapy in Lagos. Thank you so very much. We are so glad to have you here tonight. You can have the stage, ma'am. You're welcome.
Thank you. I was having issues with the slides, so I don't know if you can help me pull up the slides. And good evening, everyone. It is a pleasure to be on this platform talking to all of you. This is it's a topic that is not spoken of as much as it should, and it is getting a little bit more visibility, but it's the silent sufferer of a lot of people. And I chose to say people, not women, because there are a lot of pelvic floor issues that men are having as well. Please, you can move to the next slide. The pelvic floor is it's a very important functional part of our bodies, and it has very critical functions that we take for granted every day. And Sometimes I have patients come into my clinic and they don't even realize they have muscles in the pelvic floor. When we talk about muscles in the pelvic floor, they're kind of like puzzle muscles. We have muscles down there. Yes, we do. And you don't know you have them and they're working fine till they stop working. And the issue with pelvic floor issues or dysfunctions is it does affect both men and women. So women, we don't have the autonomy on the pelvic floor struggle. And because of where it is and the nature of where it is or what it is in our bodies, we don't talk about that. And we live in a culture where it's not that open. I mean, sex is not a topic for conversation, even between parents and children. So it's shrouded in a lot of mystery and a lot of myths. And so, which is why it is a silent struggle, because a lot of people are either embarrassed to go to the doctor, or they may have had one encounter where they may have mentioned it, but the response that they have received has not been very encouraging. So they don't talk to anybody else about it. And they try to suffer in silence. And there are medical conditions involving the pelvic floor. All the pelvic floor dysfunctions we'll discuss today are real medical issues that need to be treated. So next slide. So next slide, please. So the learning objectives. I don't know. Miss Faith, are you controlling the PowerPoint? Can you move to the next slide? Hello? My PowerPoint controller. Thank you. Okay, so what are some of the things hopefully you go away with this evening? Basically, a very basic identification of the pelvic floor, some of the issues that we're having. Understanding the importance of pelvic health, things that physiotherapy physiotherapy approach. There are pelvic floor physiotherapists who deal directly with this area, who are trained and have experience in dealing with issues of the pelvic floor. It also helps to promote awareness. Hopefully, this is going to be, for some people, it's like, wow, this kind of thing happens. So we're going to promote awareness today and educate you about pelvic floor dysfunctions and highlight the role that we play as healthcare workers in the treatment of pelvic floor. And for those who are not in the healthcare field, who are maybe just listening to this, this is something that can be treated by the healthcare professionals. Obviously, I'm coming from the standpoint of a physiotherapist. So we do have a very important part to play in the treatment of pelvic floor dysfunctions. Next slide. I don't know, I have a pop-up on my screen, I don't know. Okay, so let's basically do a brief overview on the pelvic floor muscles before we dive into some of the other conditions that we will talk about this evening. Like I said, most people are not even aware they have as many muscles as they do in the pelvic floor. And one of my first things when I have somebody come to me with pelvic floor issues is to show them the pelvis, the model, show them the model of the muscles. And once you understand what you have, then you can understand how it works and then how it stops working. So we need to understand how some of these muscles can dysfunction. The body is made up of different types of muscles. You have cardiac or smooth muscle, and you have skeletal muscle. Your cardiac muscle is that of the heart, obviously. Smooth muscle is basically some of your organs, your liver and your kidneys, they're all different forms of muscle and tissue. And then you have your skeletal muscles, which are the muscles that move your bones, basically, just to give you a brief kind of like overview. So we're talking about the skeletal muscles, the muscles that hold your bones together with ligaments and tendons. So it's basically a group of muscles that, in terms of the pelvic floor, it holds your pelvis together. It basically sits at the bottom of the pelvic bone, and it sits in the form of like a hammock. We always use the terminology like a shape of a hammock. And it sits at the bottom, and there are 4 separate layers of muscles in our pelvis. And they, like with any muscle, if you injure your shoulder, the muscles of the shoulder, if you injure muscles in your shoulder, it's going to affect all the functions of your shoulder. It's going to affect your neck. It might affect your upper back or your middle back. So the pelvic floor is no different. The pelvic floor muscles basically sit at the base of the pelvis, and if anything happens to them, it affects our daily function. Next slide. So this just gives you a basic overview. If you look down into the pelvis, so through those muscles, we have our orifices. So in terms of, for men, you'll have, their urethra that they pee from and their anus. And in terms of women, you'll have the vagina, the urethra, and the anus. So those are orifices or holes, whichever you want to look at it. But basically those that function in the pelvis are all controlled by your pelvic floor muscles. So you can see that if anything starts to go wrong with any of these muscles that you can see, it's going to affect all the functions that body part is in charge of, so to speak. Okay, next slide. So what are the functions? The main primary functions of the pelvic floor muscle. So the picture you have in front of you, in the red shading, is basically your pelvic floor muscle. It looks like one line, but like I said, it's 4 different layers. This just gives you a lateral view. So basically it supports your bowel, your bladder, and in the case of the woman, the uterus. So all those organs actually sit on top of your pelvic floor muscle. So your pelvic floor muscle, I said, is in the form of like a hammock. I don't know if you can see my hands, but basically it's shaped like this. The muscle's shaped like this. So all those organs are sitting on top of those muscles. Those muscles are also in charge of your continence, controlling your bladder and your bowel. So if anything happens to those muscles, it's going to affect your ability to be continent, okay, in terms of bowel and or bladder. And is also responsible for sexual function. And in terms of penetration and in terms of orgasm, those muscles are what we rely on to allow normal sexual activity or intimacy to occur. So when these muscles start to dysfunction, all these things start to have issues. Next slide. So why do they malfunction? What are some of the reasons? Sometimes we'd have no idea. People develop problems, and that's where, in terms of for our professional standpoint, your history taking is very important. But there can be excessive pressure or stress on the pelvic floor. For example, somebody who maybe rides a bike. I've seen a patient who was an avid bike rider, and because of the pressure of the seat of the bike on his perineum, and basically if there's pressure on the perineum, there's pressure on the pelvic floor muscles, he developed chronic pain syndrome in the pelvis from sitting on the bike. So there was a lot of external pressure. The pressure can come from within. Somebody who's pregnant, for example, we all know the symptom of a pregnant woman going to the bathroom all the time because the weight of the baby, if you remember the picture, unfortunately, I can't operate my own slides. I would have swung back to the other slide. But basically, the picture of, where our organs, how they sit on top of the pelvic floor. So if you imagine a baby on top of that, the baby is putting a lot of pressure on our bladder. Thank you. So there'll be a lot of pressure on the bladder if from somebody when a mom is pregnant. No, go back. The one with you, you're on the right picture. You're on the right slide. This one. Thank you. So you can see because the bladder and the bowel and the uterus all sit on top of the pelvic floor. If you add a baby on top of that, there's going to, in the uterus, in the terms of the woman, you see that the uterus almost curves on top of the bladder. So when there's pressure from the uterus with the baby, it puts pressure on the bladder, which is why somebody who's pregnant goes to the restroom, is peeing constantly, and the heavier they get, the more often they're running to the bathroom. Okay, you can go back to the original slide. Thank you. Yeah, you can, thank you. So for example, so for mothers who are breastfeeding, some of them sometimes suffer from painful intercourse because those tissues, after you've had a baby, lack of estrogen, which happens during breastfeeding because it suppresses your estrogen for you able to, for lactation to occur, that can cause sometimes dryness, etc., in the pelvic region, which can cause painful intercourse. And the vagina is very much reliant on estrogen in terms of its viability, the tissues, and being moist. So when estrogen is low, those tissues become very dry and frail and very easily irritable. You can have scarring from somebody who's had any kind of pelvic surgery. If they had an episiotomy where the tissues tear when the baby is coming out, or they've actually had to have other kind of surgeries. For example, I saw a patient who had cancer of her vulva, and they actually had to remove the vulva because of the cancerous tissue. So that created a lot of problems in that area for her because they actually did kind of a very radical excision of her vulva, and she basically had nothing there, which is kind of similar to what happens with female circumcision. The same kind of surgery was done for her, but because of cancer. So what that does is those muscles now, when they heal, it forms scar tissue. And with scar tissue does not stretch. It's no longer elastic. Once you cut the skin can stretch. The muscles can stretch, but once you cut into them and they heal, where healing occurs, it forms scar tissue, and scar tissue is not elastic like the rest of the tissues around it. So with that immobile tissue can cause a lot of increased muscle spasm, tightness. Obviously the muscles are no longer stretching as much as they should. So that in itself can cause malfunction of the pelvic floor muscles. And so when the muscles now, you have some kind of trauma or incident go on, those muscles can go into spasm. They can go into spasm from an infection. They can go into spasm from trauma. They can go into spasm from surgery. Pre and post-menopausal, we talked about the hormonal imbalance. That can also cause irritation, and with irritation, the muscles go into spasm. And for the men who have prostate issues, chronic prostatitis, that inflammation, any kind of inflammatory infection can cause muscles to go into spasm. And invariably, once they go into spasm, they get tight and they don't relax. And that's where the problem comes. Post-prostatectomies, where men have their prostate removed, again, those muscles, that area is very small. So any kind of intervention is going to affect the muscles in that area. So it can cause increased muscle tone, it can cause weakness, and all those things will then lead to, in terms of the men, chronic pain or painful pelvic floor pain. It can cause, obviously, one of the two primary side effects of prostate surgery are incontinence and erectile dysfunctions. But there are many other things that can go on after a male has had any kind of prostate surgery, or or prostate removed. So there's so many things that can happen that can cause those muscles to malfunction. Okay, next slide, please. So we'll talk about some of the dysfunctions, some of the things that can happen. So this is not an exhausted list. These are just the main things I would say that we see in the clinic often, but there are many other things that can go wrong. So you have incontinence of bladder and bowel. Basically, incontinence is the inability to control those muscles. So somebody who is incontinent of bladder will be leaking urine because they can't control it, or they will be leaking feces. They won't be able to control their bowel. Sometimes they can be aware of it, sometimes they're not. So those are all different aspects. We'll talk a little bit more about the different types of incontinence. Constipation. So if you remember again the picture of the pelvic floor and all the organs that sit in it. So if those muscles become tight, they're putting pressure not only on your bladder, but also on your rectum. So patients, I've seen a lot of patients, actually maybe too many, who have constipation because those muscles are so tight. They're not able to relax. For us to be able to, for normal voiding, or to normally sit down on the toilet and pee, or to sit down on the toilet and poop, those muscles have to relax. If they don't relax, nothing can come out. So if any kind of trauma has occurred, I'm calling it trauma, it's not always trauma, but if any kind of incident has happened to those muscles can go into spasm, and then they're not relaxing enough to allow that person to pee or poo. So they can have constipation, the inability to just sit down and void. Dyspareunia, that is pain with intercourse. It can occur at different stages. We'll talk about that. Pelvic pain and muscle spasm, where the muscle goes into spasm. I gave you the example of the bike rider, but also somebody who's had excessive trauma to the pelvic floor area. That can also cause muscle spasm. Muscle spasm is also part of vaginismus. So vaginismus is in women, is the inability for penetration to occur into the vagina, because those muscles are so tight, nothing can actually penetrate. Or if an attempt is made, it is extremely painful. So that's vaginismus, is the inability for penetration due to the muscles being so tight. Vulvodynia, we talked in terms of, for the woman, the vulva are the outer lips of the woman's vagina. Some patients can develop excessive pain in that area. Sometimes it's due to some kind of damage or injury to the nerve that supplies that area. And so like in my patient that I saw, this was many years ago, I saw this lady. She had cancer of her vulva, so it had to be removed. The other condition that we see often is prolapse. Prolapse is where the muscles, the pelvic floor muscles become weak and no longer, remember, one of the functions of the pelvic floor muscle is support, okay? Please go back, I wasn't quite done. Thank you. So if those muscles are not supporting all those organs and they become weak, basically it allows those organs to drop down into the vagina. So you can have a prolapse of somebody's bladder, you can have a prolapse of somebody's uterus, cervix, bowel. Sometimes even if the laxity is very extensive, even the walls of the vagina can prolapse down into the vagina. So there's nothing holding them up. So they basically just drop down. And then for men, I just spoke about that, erectile dysfunction can be where there are many causes for erectile dysfunction. We have some part to play in it, and we can help some patients, not all, because sometimes there are other comorbidities, other medical conditions that can lead to erectile dysfunction. For example, if somebody has a heart condition where, we all know that a heart attack means, the vessels become blocked because plaque formation. There are deposits of things inside the vessel that block the access so the blood is not flowing as efficiently because the vessel is not smooth and it's not as wide as it should be. So that's cardiovascular disease, when there's atherosing of the vessels. But basically, you have cardiac disease, and those vessels are not pumping blood as efficiently because those vessels have become narrowed because of plaque formation, which is why they encourage us to improve on our diet, because some of those deposits are like fatty deposits that narrow the passage for the blood. So if somebody has a cardiac condition that is affecting blood going to the heart, it's going to affect blood going everywhere, including the penis. So blood can sometimes not get into it for the man to be able to have a full erection. So, I'm doing this very quickly, but just to give you an overview how this can occur. And so sometimes those muscles are just too weak sometimes to even maintain an erection. So those pelvic floor muscles can malfunction as well to contribute to that condition. So basically, pelvic floor conditions can affect both males and females. Next slide, please. So the purpose of today is to give you an overview. I've picked 4 primary conditions that I want us to focus on, because otherwise we'll be here till tomorrow. It will be like a whole day's workshop. But basically, just to give you an overview of 4 of the most common ones that I see. Let me put it that way. Physiotherapy can help. Is it a quick fix? No. Just like with if somebody comes for you with a knee problem and you're training their muscle of their knee, they don't come one time. We don't go to the gym one time and become fit. So with all of these things, there are a variety of treatment modalities that can be used. And we can improve on their symptoms. Can we treat every single person? No medical professional can make that kind of, can make that kind of promise. But we definitely have a lot of tools that we can assist. And sometimes I find for those patients who may not get back to their original basic prior level of function, as we call it, they're always happy and feel much better because they've had an education. So educating your patients on these kinds of conditions, or educating ourselves, is a very critical part of the healing journey as far as I'm concerned. So sometimes they'll tell you, okay, I may not be where I was maybe 10 years ago, but I have improved and now I know what's going on. I don't think it's in my head. A lot of patients who come with pelvic pain have been to a lot of doctors. They've been to different specialists. They've had numerous tests done, but the pain is still there. And when they eventually, sometimes, a lot of times in various hospitals that I've worked, physio were the place of last resort. And when they finally get to us, and I'm like, I explain the pelvics, I explain the musculature, and I explain all what can go wrong, they sigh, they breathe. There's a sigh of relief that, oh, it's not in my head. I have had patients who doctors have told them that the pain was psychosomatic, that it was in their head, that there was nothing wrong that they could find. But in the medical profession, I'm using that as a blanket umbrella. Each one of us that work in that field, we all have a specialty. And because you don't understand everything that's going on, doesn't mean that's the patient's last stop. So sometimes it takes somebody else with different skills. And there are a lot of physiotherapists who are not pelvic floor physiotherapists. There are a lot of physiotherapists who are not neurophysios or MSK physios. So it's a niche, just like any other specialty. So, we can definitely have an influence and effect on some of these conditions. So in terms of incontinence, so the 4 things we're going to go over that I'm going to go into a little bit more detail. Incontinence, the pelvic organ prolapse, dyspareunia, and vaginismus. Okay, so can I have the next slide? So in terms of urinary incontinence, can I have the next slide? Okay, so urinary incontinence is a loss of bladder control. It's quite common. It's very embarrassing. It can be life-changing. I have had patients who have incontinence who don't leave their houses. Or it can alter your whole daily activity. What do I mean by that? I had a patient who told me when she would go to any new place, the first thing she will ask for is to know where the toilet is. That was always her focus. She would time how long she had to leave the house. She would time how long she stays out. So these were all things that, she can't just get up, go to the grocery store and come home. It was a whole event for her. So it can really change the person's lifestyle. They also have, and not just lifestyle, but body image, their self-esteem, because they think they're smelling all the time. Because the thing with incontinence, some patients are aware that they're incontinent and are aware when it's happening. Some patients are not. So they may not realize they've had an incontinent episode till either their outer clothes are wet or they go to the bathroom and their underwear is wet. So there's a huge spectrum in terms of severity of incontinence. And there are different types of incontinence, okay, that we will talk about as well. People always say, do you pee when you cough or you laugh or you sneeze? Okay, that's a form of incontinence. Do you have, we call it key in the lock incontinence, where you want to go to the bathroom, you've held it, maybe you've even done like a 2-hour drive. The minute you see your house, it starts coming out. Some patients, the minute they touch the door of the bathroom, it starts coming out. I used to have a patient who she would have a flower pot in her garage next to her car door because she would hold it for a 1-hour drive from her work to her home. But the minute she saw the house, her bladder was like, okay, we've arrived. So she would literally have to jump out of her car and use the flower pot by the door of her car before she can even walk into her house. So that's how much it can change somebody's day-to-day lifestyle. So it can be very debilitating and very depressing for some of these patients. Okay, next slide, please. So we're going to talk about some of the risk factors. What can cause incontinence? What are some of the risk factors? Age. And please, when I say age, incontinence does not only afflict the elderly. So, but as we get older, there are different factors that come into play. Obesity, the heavier we are, again, remember, one of the jobs of the pelvic floor is support. The more weight you have on those organs, the more pressure, the more chances of you leaking, so to speak, because there's a lot of pressure on those supportive organs. They might fail to support as efficiently as they should. Pregnancy, parity, these are all things that can affect the risk, put you in a high risk range. Ethnicity and race, some areas, they say in colder climates, more likely. Areas where people are heavier is more likely. We talked menopause, I kind of touched it briefly. Because of the change in the hormonal levels, it can affect your ability to control the musculature and the bladder. Hysterectomy, when they do a hysterectomy, they basically go in and remove an organ. So what happens? It's all those organs, if you remember the picture, supported one another. So when you now go and remove one, it changes the whole dynamics of the pelvis and the pelvic floor organs. Smoking, well, they're showing that smoking affects everything. Any kind of pelvic or perineal surgery, cognitive impairment, and that's what I was saying about age. It's not that as you get older, your bladder starts to leak. It's sometimes other impairments are additional factors. So somebody who has Alzheimer's, cognitive impairment, they don't even know when they want to go. They become incontinent. Somebody who's elderly, who cannot walk independently and is reliant on somebody taking them to the restroom, to the bathroom. Their lack of mobility might cause them to become incontinent, not because their musculature of the pelvis has failed, but because the musculature of their body has failed and they're no longer ambulatory or as mobile as they need to be to get to where they want to go independently. There's some anatomical anomalies where basically things are not in the right place or things are not open. For example, there are kids who are born sometimes where the anal canal, the anus is closed, and so they have to actually do surgery immediately after birth to create an opening. So there are different other anomalies that can happen from birth, that might need some of those anomalies. Most of them typically will need surgery immediately the child is born. And those kids typically now might have issues further on down the line because the pelvic floor has been affected. Okay, so these are just showing you that there's so many factors that can affect why somebody can become incontinent. And of course, we talked about the pregnant woman with the pregnancy is just extra force on top of those organs that will cause that. Okay, next slide. So let's talk about the types of urinary incontinence. Next slide, please. Stress incontinence. Sorry, some of the comments are popping up. Somebody said they leaked their flower pot story. Okay. Well, this was a patient I treated almost 25 years ago. So I don't know. It's not a new story, it's an old one. But anyway. So some of the types of incontinence, stress incontinence. So that is where patient will tell you, or the person will tell you, oh, when they cough or they sneeze, they leak, or they bend down to pick up something, they leak, or during an exercise class, they can't do any of the jumping or any of the high impact stuff because they leak. That is stress incontinence, because when you increase the pressure in your abdomen, as you increase the pressure in your abdomen, it puts pressure, remember, on your organs that those pelvic floor muscles are supporting. So you increase the pressure and that support system fails, and so you leak. So you'll have that about, maybe time flies so much, it could be a year ago, there was a funny, what do you call these things that go around on WhatsApp? It was one of these reels. It was a weightlifter, a lady. She was doing a deadlift. And the minute she picked up the bar, she started leaking. I mean, I'm sure it went viral then. And, so somebody like that who not only are you, because they hold their breath when they do that deadlift and they bend down, pick it up, and then they have to hold it up for so many minutes. And even though she was peeing, she did not let go of those weights. She did her number of minutes before she put it down. But literally, that was increased intra-abdominal pressure. And that's what stress incontinence is. You put too much pressure in the abdomen, it pushes on the bladder, and your support fails. And so you leak. So patients will say, cough, sneeze, laugh, sometimes it can go from 1 or 2 drops to their whole bladder emptying. So there are degrees of how bad it is. Urge incontinence is a sudden or intense urge where you feel like you want to go. The minute your brain tells you want to go, you're already going. So you can't control the urge. And under urge incontinence, there are other things like overactive bladder. That's a person that can go to the bathroom 6 times in an hour. But they're only peeing a few drops because the bladder is overstimulated. Something is overstimulating the bladder. Okay? If you're waking up 3, 4, 5 times at night to use the bathroom, that is a form of incontinence, because typically maybe once or twice. And when we're much younger, most of us, we sleep through the night. You might get up to pee maybe at 5 or 6 in the morning. But if you're getting up repeatedly during the night, then that is nocturia, is what we call it. Some people, it's triggered, the urge incontinence, I was telling you about the key in lock syndrome. It's either when they see their house, the bladder just goes like, okay, we're there, or they touch the bathroom door. Anything that the brain associates with them arriving on the toilet, and it goes. Some people, it's running water. Some people, if they go, I had a patient, anytime she would go into an office with AC, she would have the urge to pee. Sometimes she could control it, but sometimes she couldn't. Overflow incontinence is basically frequent and consistent dribbling. So the bladder is just, for every single person, let me just give you a little bit of anatomical, when the body eats, drinks, does everything, the body now deals with everything that goes into our mouths. So during the course of a day, your bladder is constantly having urine filled. Your bladder is constantly filling, okay? When your bladder gets to like a critical volume, and I think it's 400 to 600 mils, it then sends a message to your brain to say, oh, you need to go to the bathroom to go empty. Most of us can control that urge 3 or 4 times. So the brain will remind you, will say, oh, no, I'm not ready. You're busy. You're doing something, you can't get up. It'll remind you again, you're still busy. You can't get up. It reminds you again. Sometimes the 4th time it can remind you before you now. When it gets to a critical volume, your bladder says, okay, you got to go. So you must go now. But for some people, as the bladder is filling, they're dripping. The bladder can sometimes get too full because the bladder has sensors. So when the bladder stretches, it sends a message to the brain. Every time it stretches, when it's filling up. So it's when it gets to a certain volume that it'll tell the brain, those sensors will send a message to the brain, okay, you got to go, I'm full, I'm full, I'm full. For some people, the message system between their brain and their bladder becomes distorted. That's how I explain it to a patient. So every time something goes into the bladder is like, I'm full, I'm full, I'm full, I'm full. So they're constantly getting messages to go, even though the bladder is not full. So that can cause like overflow incontinence. Either they're constantly dribbling, or overflow can be when the bladder, now those senses that tell the bladder it's full are not working. So the bladder just keeps filling up, and when it reaches volume, it just starts to dribble to empty because there's no more space. So that can come in different forms. So basically the bladder never really empties completely because you don't get that signal to go, sit, and empty. And for just fun fact, when you sit down or stand up to pee, your stream should be at least 6 to 7 seconds. Most times it will be much longer if you're going every 4 to 6 hours. But if you're somebody, when you sit down to pee, you count 1, 2, and you stopped, it means you should have been able to hold it a little bit longer. And for a lot of patients, that's what we start to do bladder retraining. Just like when we potty train a baby, you basically put them on a schedule that even when you get the urge, don't go, because you're not supposed to go 6 times in an hour. So we need to now control the bladder to just quieten down. And even though things are coming in, it's not full enough for it to start triggering the brain to, you must go, you must go, you must go. So those are different types of incontinence that we come across. Keep going. There are a couple more. The other one is, I talked about the cognitive impairment, mobility impairment. Next slide, please. So those two issues, cognition and lack of mobility, can cause what we call functional incontinence. Okay, so basically the patient physically can't get to the toilet or doesn't have the mental capacity to know they need to go to the toilet. So it happens, they go on themselves. Okay, and mixed incontinence can be where you have both. You can have somebody who's constantly, every time they want to go to the bathroom or their bladder is full, they see the house, they see the door, they start going, or they cough and sneeze and they leak. So that's a combination of both urge incontinence and stress incontinence. So you can have a combination of these conditions that coexist at the same time. So this is just a picture of the stress incontinence. When you increase intra-abdominal pressure, the support system fails and you go. Urge incontinence, the brain is just getting mixed messages. Overflow is the brain, the bladder loses its sensory control. So it doesn't even know when it's full or not, and it just keeps filling. And when it reaches its optimum volume, it just starts to empty on its own. And then the functional, again, is where the patient can't get there because they need somebody else to help them walk to the bathroom. And so what we find a lot of times in the elderly is they develop functional incontinence because nobody gets to them in time to take them to the restroom. And one thing about the human body, when you do something enough times, it thinks it's normal. So because they've had so many episodes where nobody will take them and they've had to leak or they've had to pee on themselves, they now develop incontinence where they can no longer now control it, which is why I've been in settings where, for whatever reason, the patient needs to wear a diaper. And I hate when I hear health professionals tell somebody, oh, can just pee, you have a diaper now, just do it on yourself. No, we're teaching the brain for the bladder to become incontinent. That is not how we're supposed to function. The diaper is supposed to be your backup, emergency backup. It's not supposed to be your toilet. So, when we deal with anybody who deals with the elderly, please, if they're using diapers, don't tell them, you're wearing diaper now, just go. No, please, let's not do that. We need to keep people as independent as possible and prevent them developing functional incontinence because they just cannot get to the bathroom. So we need to help them and not create a problem, because when they become incontinent now, that comes with all different kinds of urinary tract infections, bed sores. The skin around that area becomes very fragile because, it's invariably, they don't change the diapers that often, so the skin now has issues. So it can create a whole list of other things. So yeah, just word to everybody, if you're in that situation, please, let's help them go to the bathroom. Even if they do have that diaper on, it's more for, it's a security blanket, not the new bathroom. Okay, next slide, please. Because sometimes incontinence can be temporary. It can be something that happens like with a lot of times with pregnancy, because of the weight of the baby, it can happen. Certain foods can cause you, sometimes it's not even necessarily incontinence, but frequency. If you take like diuretics or things that stimulate your bladder, because there are certain foods and medications that will do that. Obviously, when people are hypertensive, they give them water pills, which causes them to want to use the bathroom more. And if the person is not as mobile, they might develop incontinence. So something like alcohol can increase your predisposition for incontinence. Caffeine, some people, I always say, the thing with me and coffee, for some people, coffee, when they drink coffee, it keeps them awake. For me, I always joke and say the only way it keeps me awake is because it keeps me going to the bathroom, because it's a bladder stimulant. And for each of us, we all have different bladder stimulants. What's a bladder stimulant for me might not be a bladder stimulant for you. So you just have to know your body to know what causes you to have that. And if you already have weakness in that area, it might then lead to incontinence. So carbonated drinks, sparkling drinks, artificial sweeteners, chocolate. For some people, spicy food can also be a cause of temporary. It's a temporary thing. Once you stop these products or these foods, then that symptom will go away. And obviously, the blood pressure medication, like I mentioned earlier, can also cause you to have temporary incontinence or temporary frequency, because frequency is just a form of incontinence as well, if you're going more often than you should. So yes, so next slide, please. Hello. So these are some of the temporary causes. So we're going to look at some of the more longer lasting issues that can arise that lead to incontinence. So with pregnancy, because of the hormonal changes and increased weight of the fetus, I mean, this is persistent, but that too, typically once you have the baby and, your hormones go back to their normal levels, the bladder starts to function like you did before. So these are more persistent. When I say temporary, it means like if somebody eats chocolate, some people, the minute they eat it, they go to the bathroom. So it's more immediate. It's an immediate effect. Childbirth can cause persistent issues with the pelvic floor in general, but incontinence is one of them. We'll talk about some of the others as we go along. Changes with age, we talked about that too. As we get older, we become less mobile, we become sometimes cognitively impaired. So those are things that it's not something that stops overnight. These are all more persistent conditions. And if people don't, work on, if they're having postmenopausal issues with hormones, if nothing is done about it, then it will stay that way. And as we gain weight, again, increased weight, I've said, increased pressure on the pelvic organs can cause us to have issues with bladder control as well. Next slide, please. So the next condition we're going to talk about, so that's giving you like an overview of urinary incontinence. And we have fecal incontinence as well. But basically, that can be, again, sometimes what some people, alcohol can, if you have other conditions that lead to fecal incontinence, I do know alcohol does make it worse, because I had a patient who, he realized that alcohol was increasing his symptoms. But that can be musculature as well, in terms of weakness of the pelvic floor muscles that can cause constipation and incontinence, where you have no control of your bowel. So the next condition we're going to go over is dyspareunia, or painful intercourse. So in this condition, intercourse can happen, penetration can occur, but there's persistent or recurrent genital pain. And the pain can be before, in the process of starting intercourse, during the process of the movement, or at the end, after intercourse has been completed. And I have had men who have pain after an erection. So that all comes under dyspareunia, not just for the women. And some men can have painful erections as well, because those muscles just go into spasm and can set off like the pain cycle. So some of the causes of dyspareunia. Next slide, please. Okay, so painful intercourse can be caused by, like I said, many things. Endometriosis, which is inflammation of the endometrial lining in the female. Somebody who has pain or pelvic inflammatory disease. I remember I said any kind of infection can cause those muscles to go into spasm. Inadequate lubrication for somebody who's older, who maybe they're going through menopause, their estrogen levels, progesterone levels are they're all bouncing all over the place. That can cause those tissues to dry up and become more fragile. So, intercourse is painful. Any kind of urological disorders, anything to do with like post-surgery down there. Like I said, once you cut the skin, you cut through tissue. Once it heals, you have scar tissue. Scar tissue doesn't stretch. So that will then cause, tightness or spasm in that area. Obviously, vaginismus too can come under dyspareunia, because even if they can have penetration, the whole process is extremely painful. Vaginal atrophy, where those muscles just, lose all their muscle bulk, so they become weaker and lose muscle power. Vulvodynia is pain around the vulva, which can be neurological as well, causing nerve pain, really is what that is. And also, like I gave the example of an old patient that I had who had cancer of the vulva. So that also caused her, she just had pelvic pain and lack of issues with bowel and bladder function was what we were even dealing with. Sex wasn't even on the table. But she had, because literally all she had now were like 3 little holes and everything else was just scar tissue. So these are some of the things that actually can lead to, because for some people, and the other part of pelvic pain, which is what this is during intercourse, is some people have had a bad experience. So under this topic too is where we talk about abuse. I have had patients who have their attempt at sex has been painful, but then when we delve into their history, they were abused as kids. So sexual abuse can cause those muscles to go into spasm, because especially for those who, when it happened when they were young kids, the brain doesn't even know what's going on. So those muscles, the process was probably extremely painful. So because of the pain, those muscles just go into spasm. And this is when they're kids, and they stay there because nothing has been done. So I see a lot of vaginismus patients, primarily so, and dyspareunia patients who in their history have had sexual abuse, even somebody who was raped as a teenager, a young teenager. So any kind of trauma to that area can cause those muscles to go into spasm. And when the trauma is over, the brain still remembers that trauma. And because of that, anytime they think about anything in that whole area, those muscles just immediately go into spasm. They don't even have to be in a position to be intimate. Just the thought can cause those muscles to go into spasm. So, so there's so many factors that can be involved with a patient with dyspareunia. And so for those of us who are physiotherapists, we do pelvic floor, but your history is very, 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 very important when you're doing an evaluation for such a patient. Okay, so that's dyspareunia. The next one we're going to go through is the prolapse. Can I have my next slide, please? Okay, pelvic organ prolapse. So I described to you, this is where basically either the bladder, the uterus, the cervix, or the rectum, or sometimes even the vaginal wall can collapse down and start to come out through the vagina because the pelvic floor muscle support has become weak. So one or more organs can slip through the pelvis. Pelvic organ prolapse, basically, there are different stages. So the prolapse can happen where it's not visible, or sometimes when we do an examination for a patient who has like a grade 4 prolapse, once they open their legs for you to do an examination, whatever has come out is sitting and staring you right in the face because it's actually now come outside of the vagina. And patients will tell you when they walk, it feels like they have like a golf ball in between their legs. So any one of these organs. So the first picture shows where you have your normal muscle support, everything is in place. And then the second one shows where that muscle support has weakened, and now you're at risk of any one of those 3 organs prolapsing, or even the walls of the vagina. So that's basically what a prolapse is, where your pelvic organs start to protrude down through your vagina because the pelvic muscle support. Remember, one of the functions I said in the beginning of the pelvic floor muscle is to support these organs. That support system fails, and that's what causes a prolapse. So depending on the degree of the prolapse, like something like a stage 4 prolapse, physiotherapy might be able to help strengthen the muscle, but typically if it's a stage 4 and it's coming out, they have to go into surgery for them to give them artificial support of those organs and tack things in place to keep them to keep the organs back where they belong. So that's pelvic organ prolapse. The next slide, please. So some of the risk factors for POP. Next slide, please. Okay. Again, multifaceted. There are various things that can lead to a pelvic organ prolapse. Again, age, as we get older, our musculature does get weaker if we don't stay in shape, which is why I always tell people you're never too old to exercise, because once you start exercising, you will get the benefits of exercise. Pregnancy and childbirth, obviously, remember the whole support system, too much pressure, the weight of the baby. They've shown that genetically, people are more at risk. If your mom has had it, your grandmother has had it, you might have it. There's a genetic link. Somebody who's had a hysterectomy, if you go back to the previous picture, you see how one organ is supported over the other. So when you go and remove one of those organs, it leaves a gap, it leaves a space. So that can also cause, and depending, especially if it's a radical hysterectomy, that support system and the act of surgery alone can affect the pelvic floor muscles. Okay, we've talked about pelvic floor injury, increased abdominal pressure. Again, that would be for more so pregnancy or somebody who's doing heavy weightlifting. Constipation, because when somebody is constipated, they tend to want to push. They're always pushing, because when they sit down to poop, it doesn't just come out, which is what is supposed to happen. When you have the urge to go, you're supposed to be able to go, sit down, the muscle relaxes, and you void. Okay. Constipation is where those muscles don't relax, and for you to empty your rectum, you're now pushing for anything to come through the anus. So that act of bearing down and pushing can cause a prolapse, because you are now increasing the pressure in your abdomen. And remember, that support system is there. So you are pushing on that support system. And then with somebody who's constipated, they're constantly pushing. So it can cause other organs to prolapse. We've talked about intense physical effort, the weight, and sometimes patients who have history of low back pain. Because when you look at the musculature of the pelvic floor, it attaches to the base of your spine. Your pelvic floor muscles attach to your sacrum, which is the tailbone, at the last two tailbones, so to speak. You have your coccyx, which is your actual tailbone, and the sacrum that sits on top of that. So a lot of pelvic floor muscles attach to the lower part of your spine. So you can see that if those pelvic floor muscles are in spasm, they're also going to pull on your lower back. So sometimes patients will come in with low back pain, and their pain is actually coming from their pelvis, not necessarily localized to their back. It's because those pelvic floor muscles are so tight, they're now pulling on the sacrum and the lower lumbar spine. So they can mimic low back pain as well. So those can also cause, because when you're in pain, you tend not to want to push. So it's harder, and it can cause, when you're in pain, some people don't want to go to the bathroom because it's all intricately interconnected, and they can become constipated. And when they become constipated, they have to push, and that can cause a prolapse. Okay. So next slide, please. So when we talk about the support system, you can look, this picture gives you a good example. So the first one, I always describe the pelvic floor muscles as a hammock, okay? So the first one, it shows normal pelvic floor, good muscle tone. This is where hopefully we all sit when nothing is wrong. And when those muscles become weak, this is what happens. That hammock just drops. So it's no longer acting as your support, is now down here. So you can see how easy it is for leakage to happen, prolapses to happen. So this gives you a good visual of what happens when the muscles get too weak. When they get too tight, that now becomes almost like a straight line. And then again, nothing can come out and nothing can go in, okay? Next slide, please. So we're going to talk about vaginismus. It's a condition involving increased muscle spasm of the pelvic floor muscles. And sometimes it's an involuntary contraction because, like I say, sometimes it's a memory of an incident, just the memory. One of my first few vaginismus patients I treated, and we're talking maybe almost, well, when I started treating her, she was, well, let's say 20 years ago. Let's say 16 years ago. Typically, as pelvic floor specialists, just to give you a little bit of background, we do internal exams, okay? Because we need to go in and feel what the muscles are doing, etc. So when she came, just the thought of anybody going near her genitalia, that area, she would basically you could just even see her shoulders rise up. So you can imagine what the pelvic floor muscle was doing. So it took us like a month for me to use, we have biofeedback machines that we use then, I still use, that you put sensors just on the outside, on the outside of the vagina. And so the first time she even allowed me to put it on. So the screen shows you how contracted the muscle is or how relaxed the muscle is. So just to give you another fun fact, the normal resting baseline for your pelvic floor is around 5 to 7 microvolts, okay? When we put her on the machine, she was like 300 and something. So all I did was just put on the sensors and we were talking. And every time we would even talk about what may have happened, that number would increase. And just that is just from the thought of it, not because anybody was doing anything physical. So that's why I'm saying that for vaginismus patients, through the mental component is very, very powerful. And so when we treat, I always say a pelvic floor therapist cannot treat a vaginismus patient alone. They need cognitive therapy as well. I mean, I end up doing a lot of counseling, but I always tell my patients, you need more. If this is not connected with the bottom part, then there's always going to be a disconnect. So we have to get your brain on board with your pelvis. So I can help with the pelvis. I can help a little bit with getting the connection, but that's not my area of specialty. So I always encourage them to seek help with either a sex therapist if they come to me as couples, or a therapist that deals with this condition. They need to know it, because I've had patients give me horror stories about going to psychiatrists who just didn't know what they were talking about. But they're people who actually specialize, just like with any profession, who specialize in treating patients with these conditions. So basically, it's impossible. Penetration is impossible because those muscles become so very tight. It now closes the vagina and doesn't allow anything to go in. And when you attempt to go in, it's like you're stretching a tight muscle. So henceforth, the pain. So that's basically vaginismus. A lot of times, okay, next slide, please. A lot of times, I don't know what the percentage is. I need to check if there are new stats about that. What the percentage is of patients who have vaginismus due to physical abuse. Sometimes is from other infections, like or other inflammatory conditions like endometriosis. I've had several patients who their vaginismus, they had endometriosis as well. So those things that affect the inflammatory, there's an inflammatory process going on, can affect those muscles and increase muscle spasm. Next slide, please. Hello, can I have my next slide? Thank you. So the causes can be very different, okay? And sometimes we just don't know. It is called idiopathic. We have no idea why they've had no trauma, they don't have endometriosis, they've had no traumatic event happen. But when they try, in some cases, when they try to now consummate their marriage or have intimacy, they're unable to do so. Sometimes, and I've had like 1 or 2 patients who they did have a traumatic event happen when they were younger, and the brain has completely and utterly switched off that memory. I spoke to a patient. I never saw the patient. We actually did a phone consult because she was in another part of the world. And she did not remember the sexual abuse that she had had till she was almost 25. She just knew that the idea of sex was, the idea of intimacy just was very, I mean, she would just literally go into an anxiety attack. And she didn't know why. And I don't know what triggered it, but she was in her mid-20s when she finally remembered the incident. And I mean, like I said, it was only a phone consult. When I was talking to her, she was 41. And she had never been married and never had any kind of intimacy with anybody, had never had a relationship with anybody because of the mental struggle she went through once she remembered the incident. So when I say this can be life altering, it really is. So vaginismus is more common than I would like to see. It is very common. This is really one of the conditions that come under the silent struggle, because a lot of patients struggle with this. When they go for help, And I hear that with dyspareunia, which is pain with intercourse. When patients go to doctors for help, sometimes they're told, or even midwives or nurses, I mean, I've had many stories, oh, just lie back and relax. No, it's not a lie back and relax condition. Even for vaginismus, the muscle is in spasm. Lying back and relaxing, the muscle is still in spasm because the brain thinks that's the new normal. So we have to teach the brain that this is not the new normal. So we teach the patients relaxation techniques. We'll call it down training. We teach the patients how to relax those muscles. And there's a whole protocol that we can follow. But they've had such negative interactions. And patients tell me this all the time, that, one young lady, she went to a matron, and the woman is like, are you married? She said, no. Then you shouldn't be having sex. That was her solution to the poor woman's problem. She could never use a tampon because it was so painful. So there were other things. That kind of patient, if she had an infection and needed to use a suppository, never mind the sex part, it wasn't all about that. But she was having pain inserting even the smallest suppository into her vagina. So so a lot of times, there's a lot of emotion involved, as well as it is a medical condition. So let's not dismiss that. It is a very serious medical condition. That patient I told you about that I saw many years ago, I tell this story and it always seems like it's a story, but it really isn't. This was a real couple who they had dated. They were from Colombia. They had dated for 7 years. They had been married for 7 years, and they hadn't consummated their marriage because she had vaginismus. And when she came to see me, she and the husband always used to come. And the one time the husband didn't come for some reason, he had an important meeting to go to. I said to her, you married a saint. You really did, because he was so supportive. And anyway, fast forward, they got better. And their son turned 15 last year. And when I was in the US, I actually met him for the first time. So that was really emotional for me. But so it can be treated, I guess, is where I'm going with that. And so let's not struggle with this, and let's not keep it silent. There are people who can help. There's a lot more on Instagram and stuff about it now. There are a lot more of us that do pelvic health. So there is treatment for vaginismus. So I want that to be a takeaway from this. It's not something you have to suffer in silence. And even for dyspareunia, there are people who are in marriages. I met the one lady I saw with dyspareunia. She had 5 children. And she had just been gritting her teeth through having sexual intercourse with her husband. She delivered 5 children. And she had severe dyspareunia. And every time she would try to talk to her husband about it, he would be like, oh, she doesn't want to do it. And for her, she finally convinced her husband to come to one of the sessions. And he then realized it was something beyond her mind. So these conditions do exist. They can be treated. Sometimes there are other issues going on that might minimize the effectiveness of treatment, but on the whole, there at least sometimes for a patient, just knowing that is not imaginary. It's not on them. It's not something that the doctor tells them, oh, you're just, it's psychosomatic. It's just in your head. No, there's a physical, the pelvic floor is very much there. It's very much evident, and it can malfunction. So those are some of the things that we need to realize. Just because we don't see it, like you see your biceps or your triceps, doesn't mean it can't, malfunction. Okay, next slide, please. So as physical therapists, like I said, we have a part to play in this. Next slide. Hello. Thank you. So what can we do? Some of the things that we can do: exercises, stretches, biofeedback, trigger point releases. Like I said, we do internal exams, and some of that trigger point stuff is done internally. different forms of electrotherapy. Counseling is a big part as their first line of contact, because you're the one they come to. A lot of times they find us online or they find me online and they call. So sometimes you're the first person they're ever telling this. And so you do have to be able to empathize and give some words of encouragement, even if you can't give advice. You can give words of encouragement that, yes, this is real. Yes, there are things that we can do to help. Yes, it's not in your mind, the muscles. And when I show people the pelvis and I show them the musculature in the pelvis, then they have a visual of what they're dealing with. So that always helps. So the educational piece is critical. The trigger points and manual therapy are about the same thing. Same thing with the soft tissue mobilizations. We do internal and external. So, so we have a lot of tools in our toolbox. That's what I always say as a physiotherapist. I have many tools in my toolkit. So for pelvic floor, these are some of the tools that we can put to use to help our patients. So next slide is, typically I have mainly women, but there are men I've had patients who, the man was the one who would make sure all the homework was done. So believe this or not, I do have patients and there are a lot of people, now let me not say patients, who have never looked at their pelvic area, let me put it nicely. They've never held a mirror in between their legs to see what's going on. So for a lot of patients who come to me, I always ask, have you ever looked down there? Do you know what it looks like? And I get a surprising number of no's, but anyway. So I encourage them to look. And when we start teaching you pelvic floor exercises, some patients want to know, how am I getting better? How do I know it is working? Okay, that's where the mirror comes into place. And I tell them you can put 2 fingers, say this is your anus and this is your vagina, the space in between. Even for the men we're teaching pelvic floor exercises, that area between the penis and the anus is called the perineal body. All our pelvic floor muscles cross in that area. So when I tell patients, put 2 fingers in that area, contract your pelvic floor. If your fingers don't move, then you're not contracting your pelvic floor. Or you can put a mirror and see, is that area moving up or down? So it is important for us it's like doing breast exams for women. If you don't do breast exam, you never know what normal is to know what abnormal is. So down there is no different. So I encourage patients to do a self-exam. I mean, like I say, the men can do that to know whether they're contracting that muscle or not. Another way to do it is during intimacy, where you can ask your partner, when you squeeze, are they feeling the sensation when you squeeze during sexual intercourse? So my final slide. Next slide, please. Okay, so how healthy is your pelvic floor? So you have a hypotonic pelvic floor where the muscles are weak, so everything is hanging down. You have a healthy one where everything is up here. It's not down here, it's up here. And then you have a hypertonic, which is where most of my vaginismus patients are. The muscle is now up here. So we all need to know where we are. I always get comments about, you should teach about wellness, in not just treating conditions. What do we do to make sure we stay healthy? And part of that is doing a self-exam, making sure when you contract that muscle, it's contracting, it's relaxing. How often are you going to the bathroom? When you have a bowel movement, do you have to push? Do you have to strain? Because all of those, if you are constantly constipated for years, as a woman, your risk of a prolapse is high. So these are some of the things that, I should put together for a wellness kind of pelvic floor session for people to say, okay, these are the things you need to look at to make sure your pelvic you have good pelvic health. And I think that's my final slide. Next slide, please. So pelvic physiotherapists are an integral part. Next slide. Thank you. So, there are pelvic floor physiotherapists, and we're an integral part in pelvic health. We also deal with postpartum, women who are about to have babies, preparing that area for you to have your baby. So they don't tear, they don't, have ongoing incontinence. So pelvic floor therapists have a lot to play. My specialty is dysfunction, which is why I didn't talk a whole lot, but there's a lot we also do in pre and postpartum mothers, before they have the baby, teaching them, the low back problems, what they can do to avoid it, to make sure that their pelvic floor muscles are, stay conditioned and stretching well. We have stretching exercises. We even teach mothers who are going to have a vaginal birth so they don't tear, so that area stays supple, and the perineum, so that when they go to deliver, it's not stretched and gets torn. So there's so many other areas that we work in as pelvic floor therapists. So I hope this has been an educational piece for some of you, or an enlightening piece for others, and that with this information, we learn as we go along. I always say the more we know, the more we learn, the less we know. So I hope this was interesting and educative for everybody listening. Thank you. And I mean, this is my company, used to say TAFO Rehab. It does say pelvic and orthopedic wellness. So we do see other cases, not just pelvic floor patients, but that is one of my areas of specialty. I'm biofeedback certified to treat pelvic floor dysfunctions. So over to you, Mr. Chijioke and Ms. Faith. So I don't know if people have questions. Chijioke, you're still muted.
Oh,
thank you.
So I don't know if I can get the exact emotion I used to say everything I said when I was muted.
Oh,
but thank you. I was literally pouring out my heart.
So you have to say it again.
Those moments when you'll be sending somebody a voice note and you're laughing, and then you realize that the voice note did not send. You have to now laugh the same type of laugh. That's what happened to me right now. Thank you so much. It was a roller coaster for me personally. Before everyone else, you took me down, like I could literally see the pages of my textbooks, my notes when we're doing urge incontinence, overflow, stress incontinence, all of that back then in school. I think that was in our final year, women's health. And I could also remember, not even remember, you just made me, you put me in trouble again. Cause I don't know, somehow there's this passion awakening in me to do something about, I run away from internal. Part of the reason is because when I was in National Hospital doing my internship, whenever it's time for women to come, internal assessment, all of those things, they'll chase us out, they'll chase the men out. So I at the point I was like, what's the point of learning something that I would never get to practice? Probably probably I would never get to.
So I don't understand.
Well, I don't know why. Maybe because I don't even know. Maybe it's because Abuja is north. I mean, north
That's true.
dominated, something like that. Yes. So but yeah, I gave up on all of those internal stuff. But maybe I don't know. Maybe if I see the opportunity to pick it up again, I would. Maybe.
Yeah,
Thank you so much.
Hands-on class in Lagos. So you start moving around.
Oh, amazing, amazing. So I'll try to let me scan the comment section. There are a lot of questions, but before then, I want us to just share your experience. I mean, people were really joining. A lot of people were joining and leaving. At some point, we had about 17 to 19 people join in. And even now, I think more people are still joining. I don't know. Maybe people kept on sharing at the toward the end. I'll scan through the comment section. I saw a few questions. If you have questions, please drop them. I'll pull them up on stage. I saw a lot of interesting comments, a lot of interesting questions. So yeah, let me pull it up. Before then, I would remember. I think somebody was asking me about pelvic floor physiotherapy, and I know you are in Abuja. So, Dr. Remy, I don't know. Do you have someone working with Tafo Rehab in Abuja? Do you have an extension here by any means?
I'm going to say
I'm
not
going to
yet.
say not yet. Okay, okay, okay. So, I have a handful of physios, female physiotherapists who are, into the internal part of pelvic floor rehabilitation, and I think I can easily refer anyone. If you're in Lagos, of course, the number is on the screen. You can screenshot this. You can screenshot this for anything. I mean, everything physiotherapy. You can approach. You can reach out to Dr. Remy. You can reach out via the phone. You can follow her on Facebook. You can reach out to her through me. But then, I mean, this is one of the places you go to, and you know that you are in the right place. You are in the right place. So, um,
And the other thing
and
to
the other
say
thing to
that we
say that
I do
I
work
do
virtually
work
with a few
virtually with a
patients.
few patients. Oh, beautiful.
Yes.
Yeah. Beautiful. So, they can, I believe this numbers would, can get them across to you.
Yeah.
Yeah. Okay. So, what exercise? No, not that, not that. How someone's asking how much is your virtual consultation? I know.
I'll let Chijioke
I'll let
answer
you just
that for
answer
me.
that for me. Okay. So let me put it this way. Um, Dr. Remy is very, very much advanced. That's number one. She's experienced. I don't even need to explain all of these things. You must have seen it. For somebody to take, my fear for this topic was that it was going to be hard to communicate it well in a way that anybody who's listening will understand. But the way you broke everything down is just so amazing. So I believe they already know who you are. But this is a scratch. This is a scratch. This is my mommy. Oh. This is my mommy. We have conversations running into hours and hours, and I know her. So that said, that said, she's meant to be expensive, and normally she's meant to be expensive, but then this is it. um she can tailor something for you, right? She can
Everybody.
tailor something for everybody. So don't be afraid to approach and then ask her, what tell her your needs, and then she'll be able to work with you based off what she's offering. And then also, if that is not something that you can reach, you can always meet at your own budget and then figure out what exactly works for you in different formats, in different forms. But be rest assured that whatever the case may be, Dr. Remy is somebody that you would want to work with. I can assure you that. I can assure you that. In fact, if it has to be you having to fly, what country are you right now?
I'm in the
I'm
US.
in the
But don't
US.
worry, I'll call you back to
I'm coming
Lagos
back
in a
to
minute.
Lagos. Okay, amazing, amazing. So if you have to fly whether to US or you wait a little bit and meet her in Lagos, that's a worthy investment. It's a worthy investment. Honestly, if I ever had the money, save, I'll just fly and come and have some time. Just come and submit my head so that you baptize me with knowledge. So, let me see. I got another question. Let's see. I'm trying to find. Please, if you drop your question and I'm not calling it out, please feel free to pop it up again. So, someone asked. This is the question: Can a wounded, can a bladder wounded during a traumatic vaginal birth become incontinent even after healing?
So it depends
So
on the
it depends
trauma.
on the trauma.
I mean, yes, it can.
I mean, yes, it can.
Because the bladder is a muscle.
Because the
So
bladder is a
depending
muscle.
what the
So
damage
depending
is, was
what
it
the
actually
damage
to the
is, was it
bladder
actually to
itself
the bladder itself
or the muscles
or the
surrounding the
muscles
bladder, the
surrounding the
pelvic floor
bladder, the
muscles?
pelvic floor
So
muscles?
if the pelvic
So if
floor
the pelvic
muscles were
floor
affected,
muscles were affected,
even though the bladder has
even though the
healed,
bladder has healed,
you still have to
you
deal
still
with those
have to deal
muscles.
with those muscles.
I'm echoing. I hope
I'm
I'm not
echoing.
echoing for
I hope I'm
everybody
not
else.
echoing for everybody else. No, you're not echoing here. Let me turn off my mic. I think that's why.
Okay, so yeah, that was why. So yeah, so basically, once even so, I would need a little bit more detail. So, I mean, it was if the bladder itself, your bladder, which is a smooth muscle with some voluntary muscle from the pelvic floor, gives it that voluntary control, your sphincters. So, which one of those was affected? Because even after healing, it's like an episiotomy during childbirth. When you tear, even after they've healed it, I mentioned that all our pelvic floor muscles literally cross through that area. Those muscles, once there's been a tear, once you have scar tissue is fibrous, it doesn't stretch. You need to work on it. So if that helps.
Thank you. Somebody's asked me to come to Abuja. Yes.
Don't worry, we'll
Don't
organize a
worry, we'll
trip.
organize a trip. Oh, good, good, good. I look forward to that. I look forward to that. Okay. Um. So I get the golf ball syndrome, and yes, I had an episiotomy from my first. So that's a follow up to the first question.
Okay, so you do have a
Okay, so
prolapse.
you do have a prolapse.
And so,
And so, I mean, if
my question would be,
my question would
when
be,
you look down or
when
use
you
a
look
mirror, do
down
you
or
see
use a mirror,
anything?
do you see anything?
If you don't,
If you
then it's
don't,
not a stage
then it's
4.
not a stage
Okay,
4. Okay,
but
but
there are things that you
there
can
are things that
do
you can do
to prevent it
to
getting to a
prevent
stage
it
4.
getting to a
So,
stage
I
4.
mean,
So, I mean,
that's a classic
that's a
description
classic description
for a prolapse.
for
That
prolapse.
golf ball
That
feeling
golf.
in between the legs.
Okay, someone asked about what, let me see, about please, are there exercises to prepare and train the pelvic floor before pregnancy? And this is a really, it's a really interesting question, considering the fact that there's not so much that I mean, there's not a lot of information around pelvic floor exercises before before pregnancy. I don't think there's so much awareness about all that. Usually a lot of women get to hear about pelvic flex, especially kegels. That's the
When
one
it
you
goes
usually
wrong.
hear. When it goes wrong. Where exactly when it goes wrong, or sometimes in antenatal classes. And then I learned something about kegels and reverse kegels. So a lot of pregnant women, they go for the antenatals, and then the antenatal instructor, maybe a midwife or whoever, comes to them and is like they should just be doing kegels, squeezing and releasing, and some of them right there are in their third trimester. They are about to they're about to deliver, and then they're still telling them that they need to keep doing squeezing and doing all of that. I kind of had it the other way around towards the delivery. But then I'd like to hear your thoughts on this question and also this one that I'm bringing up.
Okay, so
Okay, so
yes, you can have, and if you're taught something before you need it, you're able to learn it. Okay, it's like when we do pre-op, when a surgeon wants to operate. I mean, and I had one recently. They're going to operate on the shoulder, no, the knee, and they wanted him to gain a little bit of strength, especially on the other knee, but they wanted it stronger before surgery. So that's basically what we're doing, is pre-op strengthening, so that when he's had the surgery, his prognosis is much better, his recovery is much better. Same can be for the pelvis. And I know I have people who have asked me this question, what, especially some of my older nieces, let me put it that way, when they hear me give talks like this, like, Auntie Remy, what can we do to make sure we don't have problems? The first thing is to learn, because those midwives give somebody, go and squeeze. If you don't know you have a muscle down there, what are you squeezing? That's the first thing. So the instruction is poor. So the person has no concept of, so that would be what would be the wellness part, is teaching people what it feels like to contract a healthy pelvic floor muscle and how to relax a healthy pelvic floor muscle. Because that's the relaxation you need during childbirth, to allow your vagina to open and stay open whilst you push out the baby. So there are exercises, is an awareness thing, to be aware that, yes, there are muscles there. This is how it works. When I sit on the toilet, how does the muscle feel? This is like down training. When I'm peeing, that's when that muscle, we have an exercise we do called the elevator exercise, right? So most of us are sitting on the ground floor. We're in Nigeria, we're not in America. If it's America, it would be first floor. So we're in Nigeria. So we all go about our business, and pelvic floor is on the ground floor. When you want to pee and you're not ready to pee, you squeeze to maybe the first floor, second floor, third floor, fifth floor, depending how strong your muscles are. And then you relax. That contraction of the pelvic floor actually switches off the urge to urinate. So that's how we can keep holding the urge till eventually the bladder is like, okay, I'm done. If you don't go, I'm coming out. And then you walk to the toilet. So, but when you sit on the toilet, that muscle now goes to the basement. That's down training. And somebody who's about to have a baby should learn that elevator concept. So it's easy for me to learn it when I'm not in pain, when I'm not stressed, than on the labor table, if you see what I mean. So yes, there are things you can do to learn healthy pelvic floor function. Okay. And so when you do now need it, it's almost second nature. You're not learning a new skill when you have so many other things being thrown at you. I can't remember. Did I answer both questions? What was the other one?
Second question is about the first one is about examples of exercises. Apart from Kegels, are there other exercises?
Okay, so
let me clarify.
Sorry, let me let you finish.
I interrupted. Okay, so I believe that's what the person was asking for. Other exercises, other possible, DIY, probably kind of exercises they can be doing.
Okay. So they're like stretches for the pelvic floor. There's stretches we do, like for a vaginismus patient or somebody who has increased muscle tone. Like happy baby, where you're laying on your back, you bring your knees almost to your chest. Anything that opens the pelvic area, pelvic floor, and the pelvic, your hip muscles actually attach to your pelvic floor. So when you rotate your hips, you're actually contracting and relaxing your pelvic floor as well to some degree, because it does take attachment to some of your hip muscles, your rotators. So those kind of stretches, some of the yoga poses, like a deep squat with your legs open, like when you sit tailor sitting, anything that kind of opens that area, that's more of a stretch for somebody who might be per tonic, increase if somebody who has increased muscle tone. The thing with when people say what other exercises, okay, the Kegel exercise, just for FYI, Kegels was the guy who invented or came up with the concept of pelvic floor therapy. He invented or he named the contraction of the pelvic floor muscle Kegels. So that's where the name comes from. So Kegel exercise basically is really a blanket word for pelvic floor exercises. So Kegels is not going to be different than me teaching you different. So Kegels is just contracting and relaxing your pelvic floor. Really, that's all it is. So when we teach you to do different exercises, depending on where you are, I don't like to give exercises blanket because, and I've seen this with patients who go online, they're having issues with incontinence. So they go online and they teach them contract, hold for 30 seconds, contract. Okay, so this is a bit of an eye-opener for some patients. When patients have incontinence, right, they're leaking and they're not aware, it's involuntary, the bladder just empties. So they're already self-conscious about leaking. They don't want to leak. So what does the brain do? It makes that muscle go into spasm, kind of trying to stop you from leaking. So the brain is holding your pelvic floor muscle like this. So it's so tight, so you don't leak. But because the condition is still there, you're still leaking. So what has happened is in your brain's attempt to stop it, it has tightened those muscles. And now your muscles are in permanent spasm. But you're still leaking. So what we have to do, and which is why sometimes patients say they were doing exercises online, it got better a little bit, then it got worse. You can't tighten, so the muscle is in spasm. The first thing we need to do is relax that muscle. Once the muscle relaxes, you are then able to do strength training. But if the muscle, I always use my shoulders. Let me see if I can show you guys. I always use my shoulders. So normally my shoulder is relaxed, I'm fine. My bladder and bowel, I'm controlling it. Then I start to leak. So slowly my muscles come up, kind of holding me. So my brain is saying, don't leak, don't leak, don't leak. So my muscles stay here. Don't leak, don't leak, don't leak. It stays here. So now my pelvic floor muscle is living up here permanently because your brain is trying for you to stop leaking. Meanwhile, you're still leaking because the muscle is weak, even though it's in spasm. So when you go to online, you learn Kegels, you squeeze, 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 you relax. Squeeze, 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 you relax. Those first few sessions of squeezing and relaxation allows that muscle to relax a little bit. But because you keep going and those things tell you, hold for 30 seconds, you are now stuck back up here, and sometimes even worse. So when we see patients who are incontinent, invariably they're up here. So I have to teach them to bring that muscle down here. So when they squeeze, it stops. When they relax, it comes back down. The thing with muscles, for optimal contraction, you need optimal relaxation, which you don't have if you're up here. So when you're trying to squeeze, you don't have much excursion of movement. Till you relax that muscle, that's the down training that you talked about. And then you can now train the muscle to what you want. If it's somebody who has stress incontinence, you want to train their fast muscles because we have fast twitch muscles. Because when you cough, laugh, or sneeze, it's your fast twitch fibers that contract. But to hold you during the day, you're walking around to stay is your slow, the marathon runners keep you continent. So I hope that answers your question. So Kegels is just a terminology. And depending where you are in your journey, depend the exercise prescription.
Okay, thank you very much. Someone asked whether when there is a problem with the pelvic floor, can it affect childbearing?
Depends on the problem. What do you mean? That's a very wide question.
Let me see.
If you have vaginismus, yes, you can't conceive because you can't have intimacy. I mean, that's the
I mean,
extreme
that's
end.
the extreme end. Mm.
So it depends what
So it depends
exactly
what
they're talking
exactly
about.
they're talking
That's
about. Yeah,
very
Faith,
broad question.
Faith, I think you can type the question again. Like, answer the, yeah, because I think it was in the private chat. So, what kind of problem? What kind of problem? So probably she was referring to, all the some of the pelvic floor dysfunctions, pelvic floor issues you've mentioned, if it can affect childbearing. And then I was wondering, childbearing, what what
What part of
um
it?
what part of it? What
Induction,
part of it?
delivery.
So yeah, said when the pelvis is small. Okay. I mhm. And I
Okay,
think
I'll give you an
I'll give you an
example. I had a
example. I
patient
had a
who I
patient
wasn't
who
treating
I
her for
was
pelvic
treating her
floor,
for pelvic floor,
but she was
but
very
she
tiny and her pelvis was very small. She could still conceive, and ironically, she had like, this was here in the US. Her babies were like 12, 13 pounds, which is about 6 kg. She had big babies. But what happened in her case with the second child, because she had 3 kids, each one got bigger. By the third one, okay, it basically just split her pelvis open. So that was a problem we had to deal with postpartum with her third child, because the baby was too big and the pelvis was too small, but the baby sat in there and just did its thing. So, I mean, that's an extreme case. But yeah, so a small pelvis does not stop you getting pregnant or having a baby, I guess is what I'm saying. It's just the baby might cause a little bit more trauma because of the size of the baby and the size of your pelvis. And that kind of person shouldn't really deliver vaginally, because that puts even added stress on the pelvis. So, they will have to maybe have a C-section. I mean, I'm talking kind of off the top of my head. It needs to be a little bit more specific.
okay. Okay. Thank you very much. Somebody asked, she mentioned, I think that was a continuation. That's a continuation of one of the questions. She said, I can already touch my cervix anytime I'm trying to pull. I always have to use 2 fingers to push it back up. I need help, preferably non-invasive.
Okay. We can do a phone consult for that one. I don't know. I need a little bit more history. I mean, some of these things, you can do virtual. I mean, especially if she doesn't want it, because virtual works. It does work. The virtual therapy aspect of our work. I always like face to face. I'm just a human person. I like people, but that sounds very cliche. I like people, but I like that face to face interaction. I love being a physiotherapist, and that's the part about physiotherapists that I love is interacting with people. But we've had cases where we have done it virtually. So, and especially for somebody who doesn't want that hands-on, the virtual will work fine for them. And
Okay.
I don't like prescribing exercises one comment. I like to have a history. So I'm not going to give anybody an exercise protocol on this program. You know what I mean? Without having done my due diligence. So just so people don't think I'm skating over their request.
Exactly. And I think this is what differentiates a professional from a random content creator, because I know I sometimes I wonder how people get the confidence to prescribe blanket exercises or medications or whatever online, because I think it can backfire. It can always backfire. It can always lead to a lot of trouble. So yes, I'll drop her. Those who are here, please ensure you're in the WhatsApp group. Faith, you can copy the link to the WhatsApp group and drop it here in the comment section. So so sorry. I saw a comment and I started laughing again. She said, "Is there a CJ discount, ma'am?"
Of course.
Wow,
You see,
this
I
is the
didn't even
first
have
time
to
I'm
refer to
seeing
you. I
it.
could answer that one myself.
Oh, that's amazing. That's amazing. Thank you so much. This is hilarious. This is the first time I'm hearing CJ discount. Thank you so much. Thank you so much. Yes, please do see her virtually. I'll be glad. I'd really be glad that you get the value that you're looking for. It's assured. It's assured. Be rest assured that you will. So someone asked, can a prolapse affect childbearing?
It can make it worse for sure because of
It can make it
the
of
pressure
the
from the baby. So, I mean, somebody who has a prolapse during pregnancy, I mean, there are a lot of precautions that are going to be needed to be taken, especially with their activity level and even the kind of exercises they can do as well. So they have to manage it well. Otherwise, postpartum, it can get worse. It can get worse. So you have to be cognizant of it. If you already know you have it,
if you already know you have it, and then
take precautions.
Okay, so I'd like to ask this one. I think with all the questions I've answered all the questions. I mean, I've asked all the questions that I saw in the comments. I don't know if there's any that if I did not mention your question, sorry, my eyes just went through and probably skipped maybe one or two. But I would like to ask, you know, even though you are not a dietitian, I know that there would be some implication of what people eat and how it affects some of these conditions, especially something like prolapse. Um, do you regularly work with dietitians, or do you offer like basic dietary advice? What should people know about what they eat? Because I think in this part of the world, um, sometimes people may not really get enough information about certain things, and it may be affecting their both the management and recovery and all of that. And then again, a lot of people may trivialize the advice that they get from their regular visits to the doctor or the natal, whatever, anything. So does it really have a significant impact on the condition itself, like our dietary habits?
For something like prolapse is more from pressure. But like your continence, definitely. Constipation, 100%. Because there are, like on my slides, there are bladder stimulants. So there are things that will make you more prone to stimulate your bladder. And there are foods that will constipate you. And with constipation, you're then at risk for a prolapse. So in a way, I guess, yes, there is an indirect road from diet to prolapse. So you want to make sure you're eating foods that enough fiber and mixture of the food groups to make sure you are having regular, non-pressured bowel movements. And with the bladder stimulants, each person is very different. What's a bladder stimulant for me, it might not be a bladder stimulant for you. So you have to listen to your body. That always sounds very very trite and very cliche, but it's true. There are times we eat stuff and your body's like, what did you just put in me? But we don't listen. And we keep doing the same thing over and over again, till it then becomes chronic. So we sometimes have to observe things. Oh yeah, my stomach was running yesterday. I don't know what I ate. Yes, you do. Did you eat it the day before? So you look at all what you ate that day that gave you those symptoms. So we have to be very cognizant of what we're eating. I mean, the word that your body is a temple is really serious. We all don't pay attention. I'm going to put myself inside that as much as we should. But yeah, what we eat does matter. It really does matter in terms of your bowel habits, especially your bowel and your bladder habits. But it's individualized. And you have people who are diabetic, who cannot eat this or eat that, and they must eat this. You have people who have thyroid issues, you have people who have gout. So depending on some of the other comorbidities that the person has, that what they eat has to be tailored. My disappointment is that I've yet to, I guess there are one dietitian I've worked with, maybe two, I can't even remember the second person, I don't even know if they're in Nigeria anymore. And they go very much holistic route. But the last encounter I had with a dietitian in Nigeria was for a child. And I was very disappointed. I'm not going to lie. So my little advice seemed to have worked better than what the dietitian came with, because what they were coming with, I was like, huh? It was kind of like, ooh, okay, no, we don't want that kind of thing. So, but I'm sure there are good ones out there. I just haven't been blessed with meeting them. I would love to. So yeah, diet really does play a factor in our gut. And now there's this new trend with anti-inflammatory diets. So there are foods that actually can increase the inflammation in your body. And one of the things that can lead to muscle spasm and muscle imbalance is inflammation. And we all have it to some degree, but sometimes it's elevated because of foods and just our activity, with other disease conditions that may be going on in our body that might start it off, and then we make it worse with what we're adding to it. So I don't know, that's very general, but yeah, I can't profess to have any hard and fast rules.
Amazing. Now this is another question someone asked. Okay, I think it's not more of a question, but she said this thing join will cause my postpartum depression. So, from your experience, has there been significant links between pelvic floor dysfunction of any kind and postpartum depression, either with the first delivery or subsequent births?
Okay, if you have postpartum depression in the first one, I mean, the chances are it will recur. It's not hard and fast. It might not, but it could. And the pelvic floor dysfunction comes from probably the birthing process. And if you are having issues with that, then depending on this, I'm putting me into the psych realm now, but depends on your partner. I'm going to use the word partner, husband, whatever you want to use. In America, we have to be politically correct, so it's partner. But husband, depending how understanding they are, because I have had cases where the woman is overwhelmed, having had a child. So of course, sex is the last thing on their mind, but it's the first thing on the husband's mind. So we all have to realize life is what it is. So there are men and there are women, and we all think very differently. So if you don't have somebody who's understanding or realizes something like that exists, that postpartum depression that you have and being forced to engage in intimacy can lead to dyspareunia. Your mind is not there, the muscles tighten up, and you can then have dyspareunia. So yes, it can basically lead to that from, and I have seen postpartum vaginismus as well. Ironically, yeah, it does exist. So some of these conditions can happen after delivery, and it can either trigger or exacerbate postnatal depression. And then the other social, let me call them social elements as well, can make the symptoms worse. So it's all very
interconnected. Beautiful. Thank you so much. Thank you so much. And then finally, I'd like us
To close with this interesting conversation, it's also quite controversial. It's a deep one and it's very sensitive. And that is, there's this practice here in Nigeria. I've run into trouble with some gynecologists and some midwives on Facebook. I know there was a point I made series of posts about this, and they were trending at the time. Those posts ran into hundreds of thousands of views, cumulatively millions of views, and a lot of women were speaking up. Meanwhile, a lot of the professionals were bashing me. And this is the issue. Someone raised it here, and the issue is this: in some hospitals, a woman is pregnant, she is going to deliver, and then just because she's primary gravid, just because that's her first issue, they give her an episiotomy. You know, and sometimes this episiotomy is done without her consent, without express consent. And one gynae was telling me that after there's a form that they will fill during their antenatal. So it's not necessary that the woman has to be told. Then some midwives said, "Oh, that the reason they cut without now another bad practice, cutting without anesthesia of any form," and they will say that the pain of the cut of the labor is already too much, so it will mask the pain of the cut. So they just bring out a pair of scissors and then they cut. Now again, the woman is feeling disempowered. They cut her without her consent. They cut her without epidural. I mean, without anesthesia of any kind. And then after the cut is done and the baby is out, they still go ahead and stitch without anesthesia. So a lot of, from my own side, a lot of women that I have interacted with, and they shared their stories. I didn't know it was that popular until I posted that. I didn't know it was like a common practice. So a lot of women were DMing me, a lot of them were commenting. I was speaking with some of them, and they were telling me about the mental battle that introduced them to. So I'd like to know, from your wealth of knowledge, wealth of experience, and also as an advocate, as a woman, what can you say about this? And then how can we go about advocacy? How can women begin to also advocate for themselves? So yes, this is
I
what
think
I'd like to ask.
we have to be more vocal. We have to stop thinking that just because somebody's a doctor or nurse, they know it all. None of us does. None of us. And sometimes we try to play God when we have no business doing that. And I think as women, we need to speak up. When we're going into delivery, these are the kinds of things, but some people don't feel empowered, but they need to feel empowered to say, if you're going to do this, I need to know, and I want this. Tell me you can't do it in this hospital, let me find one that will do it. Because we live in a society, unfortunately, where, your word doesn't seem to hold, you can't, people don't speak up for themselves. So I think that's what we need to do. Empower women to know that it is your right to say what you want or do not want. There are different studies to advocate for and against. Some people say if you allow the woman to tear, the tear is normally worse and not, it can go in any direction. Whereas if you cut, then it's a cleaner trauma, because it's all trauma, and easier to sew up and all that. But none of that should be happening without giving the woman anesthesia. I mean, I would want to find out whoever is saying that the pain of childbirth overrules the pain of cutting somebody through 4 layers of muscle with the scissors. Have they had their vagina cut with the scissors with no anesthetic during childbirth? If you haven't had it done to you, don't tell me how it feels. Don't tell me how it feels. I had an episode, this is totally not, well, it was indirectly childbirth. I did go in to have a baby, and basically they did a C-section. It went very wrong. That's a story for another day. So because I was in ICU, blah, 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 they had to be taking like arterial blood. They needed to know my arterial blood gases every day. Now, I don't know whoever in this room has ever had arterial blood drawn. So your arteries are very deep. It's not like your veins that are more on the surface. So when they go in to take an arterial blood sample, it is excruciatingly painful. And so they were doing this to me virtually every day. And one day I said to the doctor, no more. Oh, it's only a pinprick. And I asked him, have you ever had arterial blood drawn from you? And he said, no. I said, then don't tell me how it feels. And they stopped because I flatly refused. And then they had to put in a PICC line in my neck, but they put me to sleep to put that in. And then they could get all the arterial blood they wanted. But if we don't speak up, don't tell me how something feels if you haven't had it done. If you've had it done, then have a conversation with me. And I think if we all take that stance, people will back off, because this guy was like, no, I've never had it done. Then how the hell can you tell me how it feels? You cannot. So please don't tell me how it feels. So, but in medicine, it's not until you undergo everything that you can practice. So I don't even want to say that. But there are certain things that I think we can have autonomy over. And that is one of them during childbirth. And is it safer for you to cut me? Okay, fine. At least give me a little bit of anesthetic and inform me that you're going to do it. That's all I'm asking. I'm not saying don't do it, because I want my child to be delivered safely and I want to be safe after delivery. So, I mean, that is not, we're not arguing about that, but it's the process to which we get to that we need to change, not necessarily how it's done. Because if you explain it to me and it makes sense, I don't have a problem. But don't do it and then extrapolate that, oh, the pain is worse than giving birth, so you don't need it. How do you know? Have you had that done? If you're a woman and you're saying that, shame on you. But sometimes it's an emergency thing, they have to do it, which is different. But, you know, when people make very trite comments like that, that's what I get upset about. If you're coming at me with an educative point of view, that look, it's safer, it's cleaner if we do the cutting because, you know, the baby's head is big, blah, 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 blah. Okay, we're going to give you a little bit of anesthetic to do it. I mean, yeah, okay, no problem, go ahead. But don't do it and then you're making comments like that. I think that's where the problem lies, is when people now, like the girl with vaginismus who went to a midwife and said, look, I think I have vaginismus, I'm having problems, you know, with, I don't know if she even said like it was sex. I don't even remember. But she obviously knew because she couldn't even use a tampon. And the matron's thing was, how old are you? Are you married? You shouldn't be having sex anyway. So that was her solution. but she came to you with a medical problem. Don't trivialize it. And don't be judgmental. Do your job. Be a medical professional. I don't need you to be my conscience. So, I think that's where I think we need to empower ourselves to know when to say no and to say, okay, give me a good reason why I should say yes. Give me a good reason why I should say yes. So we don't want to deny care and end up having a problem. But if you're going to provide care that you think is going to be life-saving and critical, explain it to me and just let me know and get my consent. So some people will say, okay, in the civilized parts of the world, you can't do that. So I don't know if that helps, but like you say, it's a touchy subject.
Yeah.
But I think
the
process is what needs to change.
Very, very true. I think we would have that. We would have this. I would like us to continue this particular conversation. I would like us to continue it on the group because it's a lot. It's a lot. Many women have a lot of stories to tell. Many women have so much stories to tell. I wouldn't have known if I didn't open that can of worms. There's a lot of corruption that happens with episiotomy. There's a whole lot. In fact, it's as if over here we have everything upside down when it comes to episiotomy, from frequency to the practices surrounding it, to administering anesthesia, to repair, to aftercare, all of those things. A lot of women are left to figure things out on their own. No guidance, nothing, no post repair. Because I think in some countries, following episiotomy, automatically you are referred to physio for post-op care. Post episiotomy repair, physiotherapy, to do internal exam and all of those things, follow up on the care plan, healing time of the wound and everything else. But here, they'll just cut the woman, stitch her up, and then tell her to go and get a sit bath and put small salt in water and be sitting on the warm water, and that's all. And a lot of women just struggle. They just struggle through. So I think it's a conversation that's worth having. We'll do it in our group. So thank you so much. Thank you so much, Dr. Remi. This has been amazing. It's been amazing. It's been amazing. Like 2 hours, 17 minutes, and it's looking as if we just started. This is phenomenal. It's not truly beyond no hype. There are not many people that me and you. We used to gossip very well. We used to gossip. It's not many people that I can sit down and listen to them for up to 30 minutes and I won't back out. Sometimes I'll just I'll just put my phone on I'll just turn it on and I keep my phone. Sometimes I'll reduce the volume just so I don't hear what they're saying, and I'll drop my phone somewhere, because some people, I don't know, Sha, I can't say, but you're amazing. You're an amazing teacher. I mean, it flows. It's in the blood. It's just flowing. I believe that everybody who attended today, they have the same testimony. So please, if you joined in today, kindly send me a feedback. Okay, send me feedback. Put it on the group. We'll open the group and we'll be watching very closely, because I don't know, sometimes some random human beings will just jump into a group and start sending all their scam links. So we'll try and monitor that. But I think the group is open now. So please help us and share your experience in tonight's session. Share your experience, talk about it, so that next sessions will have more people who would want to join in. The replay is going to be available. The link is there. The same link is what as much as you want to, it's going to be available. So yes, thank you so much, Dr. Remi. Thank you. This was a very, very wonderful one. Very wonderful. Very, very wonderful. to hit the right spot. Somebody said, thank you for going straight to the point. And that's just it. Like you were hitting it at the right. Thank you so much.
You're welcome.
Thank you.
You're welcome.
You're welcome. You're welcome. All right. Bye, ma'am.
Good night.
Good night. Good night. Good night. Bye, everyone. So,
Okay.
yes, I'm going to leave the take a screenshot, please. Take a screenshot of this, so that you can easily reach out to her. And again, the group, I'll tag her on the WhatsApp group. I don't know. I hope I remember I hope this is the link. I'm going to send the WhatsApp link. I hope it's not my family group chat link. But let me see if it's the right link. I just hope, please, if it's not the right link, somebody can inform me. So try and see link here and join our community if you're not already there. So if you're viewing this directly from YouTube, or maybe somebody posted it somewhere and you joined in, Okay. So I didn't even know that my phone tripped off. Yeah. So I didn't even know that it was still showing. But yes, it's the end of the session. Thank you very much. Thank you very much. Mm. Let's go to the group. Don't worry, the gist has not finished. Let's go to the group, the WhatsApp group, and continue what we started. Okay? Let's go to the WhatsApp group and continue what we started. Faith.
Ah,
Okay, what happened? Where did you go to?
sorry, a call came in.
No problems at all. No problems at all. So we are done. We're done.
Done.
So yes, we're done.
Is it just
Yes.
us?
No, we're still live.
Okay.
Yes. So I'll end the live session now. So everyone on the call, you can head to the WhatsApp group. I was asking you to send them the link, but I
Yes,
don't know.
I didn't hear you. The link to what? I didn't hear what you said.
To the group, to the WhatsApp group, Healthy Wealthy Moms WhatsApp group. Please check if it's the link that I shared. I hope it's not the link to my family group chat that I dropped here. Please check.
Okay, I cannot access okay, no recording. Okay, comment. Oh, okay.
Just confirm
Where
whether it.
I can find it. Okay. Let me see. Okay. It's going to take a while. Okay. Okay.
It's the right link, right?
And then I'm checking out. I cannot access. It's not clicking.
Okay, no problems, no problems. I think those who would want to join the group, they will have to find a way. They will have to find a way to reach out to me. Maybe a comment on YouTube or my number. Let me just drop my number. Yeah, I think that works better. Let me drop my number 090 090 30370115. Yeah, so anybody who wants to +234 is the code, +23490 for those who are out of Nigeria. So anybody who wants to join the group and see, if you see this, you can reach out to me and I'll add you. So yes, do have an amazing day, everybody. Bye. Don't forget to share your feedback. Please don't forget. Please. Bye, everyone. And subscribe to my channel, please, so that next time you can get the update about our next sessions. Bye. I've said bye like 1 million times.